So, continuing with the musculoskeletal system, we will be talking about a few metabolic disorders affecting the skeletal system. So, we continue with the metabolic disorders of the musculoskeletal system. I would begin with acromegaly. When we talk about acromegaly, we'll be predominantly talking about the X-ray of the skull, X-ray of the hand. The skull would show a thickened skull vault, enlarged paranasal sinuses that we see over here, an enlarged pituitary fossa, and prognathism, which is an enlargement of the mandible that we see over here. Now, in appendicular skeleton, what we see is there's an increased width of the bones, as we see over here. There is tufting of the terminal phalanges, giving an arrowhead appearance. Now see, this is over here, this is a case of acromegaly, and this is what I see over here. So this is an arrowhead appearance caused due to tufting of the phalanges. There's widening of the joint spaces. And another imaging finding which is very peculiar to acromegaly is an increase in the heel pad thickness. So which is if it is females when it is more than 21.5 millimeters, and in males when the heel pad thickness goes to more than 23 millimeters. Another important metabolic disorder is just the hyperparathyroidism, wherein you get the osteopenia, you get subperiosteal bone resorption, you have a pepper pot skull, brown tumors, basilar invagination, codfish vertebral bodies, and pathological fractures. Now, if you look at this X-ray of the hands, both the hands, this is a case of hyperparathyroidism. They have, osteopenia, there's subperiosteal resorption over here. And so this is pretty typical for hyperparathyroidism. Another important metabolic disorder is the scurvy, commonly seen in the pediatric age group. Earliest signs are seen within the knee. So these include osteoporosis. There's a Wimberger's sign, which is loss of epiphyseal density over here. So this is the epiphysis, and there's a loss of density. There's a dense zone of provisional calcification over here. This is a dense zone of provisional calcification along the lower end of the humerus. There's a Trummerfeld zone where you have the metaphyseal lucencies over here. Your metaphyseal corner fractures, which is also known as a Pelkin spurs, and periosteal reaction due to subperiosteal hematomas. Apart from scurvy, another metabolic disorder that you should know about is Rickets, because this Rickets, scurvy, hyperparathyroidism, and acromegaly, these are the four of the most commonly asked metabolic disorders within the exam. Another thing is thalassemia. So this is a typical hair on end appearance that we see over here. This is, or also known as a crew cut appearance. This is generally seen due to extramedullary hematopoiesis. So this causes thickening of the skull vault. So moving on from the disorders, the metabolic disorders, we move on to infections. Now this is an MRI of the humerus showing abnormal marrow in the humeral diaphysis, and over here this is the normal marrow, this is the abnormal marrow, and this is basically a Brody's abscess or an osteomyelitis. So on many occasions MRI is more sensitive in picking up osteomyelitis rather than the X-rays, because the changes in the MRI will precede those of X-rays by at least 2 to 3 weeks. So in case you're suspecting due to the clinical parameters, if the X-ray is normal, then it would be worthwhile considering, worthwhile to do an MR. Another patient over here, this is a coronal stir view of the sacroiliac joints. This is your right sacroiliac joint, and this is your left sacroiliac joint. And over here, what you see is, there's an abnormal marrow over here. There's mild fluid within the joint, and this is very typical for sacroiliitis. Now, sacroiliitis, they can be of two types. One is, inflammatory, and the other is the infective types. Inflammatory types, there's a long list where you have the HLA-B27 spondyloarthropathies, which is like, associated with ankylosing spondylitis. There's Retter's syndrome associated, then other arthropathies associated with inflammatory bowel diseases, and so on. And infective in our country is most commonly due to tuberculosis. So moving on from Sacroiliitis. Let's go on to the internal derangements of the joints. Now over here in an X-ray, what you see is a radio opaque lesion which seems to have been detached from the articular surface of the femoral condyle. So when we do an MRI, what we're trying to see is we are trying to evaluate the osteochondral lesion which is over here, and we can see the fluid which is going in through the defect over here. So which indicates that this is an unstable fragment. So if something is suspected, an intraarticular pathology is suspected, even if you pick it up on an X-ray, further evaluation with MRI is mandatory, because before going in for a surgery or an arthroscopy, this will give you much more detail about the internal structures of the joint. Coming to the periarticular soft structures, let me tell you, superficial soft tissue masses, although MRI is oftenly used, let me tell you, ultrasound is extremely a superior modality in evaluating soft tissue structures. Now, this is the Baker's cyst. So this patient shows a fluid-filled sac-like structure along the posterior medial aspect of the knee joint. So this is actually a Baker's cyst, which is seen so well. You don't need any fancy investigations like MRI for this, and the diagnosis is quite clear-cut. Another thing is a soft tissue lesion around the wrist joint. This is your ganglion cyst around the wrist, and this cyst has it's a lobulated structure containing fluid, and it does not show any vascularity. This is a slide showing power Doppler, but there's no vascularity. Other masses include, soft tissue masses include, this is a lipoma. This is a T1 weighted image, coronal image of the shoulder joint. So this shows, this is the teres minor muscle over here, and this T1 hyperintense structure, which is there within the teres minor, which is an intramuscular lipoma. Coming to malignant lesions of the bone, so this is basically an aggressive lesion over here having a wide field. This is a malignant lesion of the bone having a wide zone of transition. Now, when we describe bone lesions or bone neoplasm, we always talk about zones of transition. So the lesion might have a narrow zone of transition, or it might have a wide zone of transition. When I say transition, it's like this is the interface between the normal and the abnormal bone. If the lesion is benign, like a simple bone cyst, the zone of transition will be abrupt. I mean, this is the cyst and this is the normal bone. But if the lesion is aggressive or malignant, what you'll find a broad or a wide zone of transition. That means it will be an indistinct zone. You will not be able to differentiate between the normal bone and the lesion very well. So this is known as a wide zone of transition. So in this case, what we see, you see a moth-eaten pattern, and over here, and there is destruction of the cortex, and there's a soft tissue lesion over it. Another thing which is very typical for bone neoplasms is periosteal reaction. So for osteosarcoma, what you'll get is you will get your sunburst kind of an appearance. You'll see an onion peel sort of an appearance which is seen in Ewing sarcoma. Now this is another patient which shows an ill-defined lytic lesion within the tibial diaphysis over here, and as you can see, the transition zone between the abnormal and the normal bone is quite broad. So this, I would think, is an aggressive lesion, and over here on either side of the bone, what you'll see is a typical, lamellated kind of an appearance, or an onion peel appearance, which is quite characteristic of Ewing sarcoma. Another thing to remember is, quite often osteomyelitis can mimic the same way. Hence, it's not always easy to differentiate between an aggressive bone tumor or an osteomyelitis. Even the MRI won't give you the answer, nor will the X-ray. Ultimately, the biopsy is going to give you the exact answer. Okay, so again, we look at this. These are these lytic lesions within the right iliac bone and the greater trochanter. So this is how it appears on the axial image. This is how it appears on the coronal image. And this actually turned out to be metastasis from the renal cell carcinoma. So Generally, renal cell carcinoma, they produce expansile lytic metastasis. Another lesion which gives a similar appearance is your thyroid. Thyroid can give expansile lytic masses. One thing you need to know is your CA prostate. It gives you sclerotic mets. You need to know that what are the lesions which give you sclerotic metastatic lesions in the bone, and that is prostate. This is a very important point which you need to know because this will come for MCQs. Now, when we talk about imaging of the spine, obviously the first thing that you begin with is an X-ray. Now, this is your MRI of the spine. These are sagittal images. This is what you'll see over here. This is your T1 weighted image, and over here what you have is your T2 weighted image. How do I know this is a T1 weighted image? Over here this is the cord, and around the cord what I see is dark fluid, and over here what I see around the cord is bright fluids. Like I said, World War II, you got to remember, water is white on T2. So over here this is a T2 weighted image, T1 weighted image, and you have to remember that fat looks bright on T1 and T2 images, weighted images. So quite often, even if the X-rays are normal, the patient might be in severe pain. So what do? In MRI of the spine, you will see a disc bulge or a disc protrusion. Disc bulge or disc protrusion is not very well seen on X-ray. So if the X-rays are normal and if the patient is still in severe pain, we do an MRI of the spine. So when we do the MRI of the spine, what are we trying to look for? We're trying to look for the cause of pain. Is it a degenerative degenerative changes in the spine? Is it a prolapse intervertebral disc? Is it a facetal arthropathy, or is it due to an infection? Is it due to a tumor? So MRI should give you these answers. And this is another case, showing extrusion of the disc, and it is causing significant narrowing of the central canal. Now, so I know this is a session on musculoskeletal imaging, but I will be covering a few lesions about the cord as well. So how do we describe an intraspinal lesion? This is a T2 weighted axial image through the cervical spine. So what you have is a cord over here, what I have shown. This is a dural covering around the cord, and this T2 hyperintense, or the bright appearing structure over here, is your CSF around the cord. This is your outer limit of the cord. So you have, and outside the dural sheath, what you have is pretty much your bone. So the lesions within the cord over here, they are known as intramedullary lesions. Now this would be, myelitis, your gliomas, your ependymomas. These would be your typical lesions. The lesion between the cord and the dural sheath, this we would be classifying it as extramedullary intradural lesions. So they are extramedullary, that means outside the cord, but they are within the dura. So extramedullary intradural lesions. And there will be other lesions which are outside the dura. So they would be extradural lesions. So common extramedullary intradural lesions would include neurofibromas or meningiomas, and extradural lesions would include anything like infections, epidural granulation tissue, bone tumors. And there are certain lesions which do not respect any of the spaces. If you have a metastasis or even infection, they might include all the three spaces. So that's how we classify a spinal lesion. Over here, now look at this appearance. This patient came with tingling numbness in both upper limbs. So what we see over here is this is actually a cord, and there's a bright structure within the cord. So what this is over here is a T2 hyperintense structure, and this is a sagittal image. So when I see there's a dilatation of the central canal, so this is a very, very classic. This is your syrinx, or syrinx which involves dilatation of the central canal. Okay, coming to vertebral compression fractures. If I have to tell you what are the causes for compression fractures, they might be traumatic, they might be due to an infection, they might be infection like tuberculosis, or they might be due to a neoplastic process, most likely to be metastasis. So when an old person comes to you with a compression fractures, your primary concern is this due to a metastatic disease process or not? And if the compression is happening, what is it doing to the cord? Is it compressing the cord or not? So once you identify, you look at the marrow abnormalities, you try and see what is happening to is there a paravertebral soft tissue or not, and you try and characterize the cause of the vertebral compression fracture. So this case is, there's involvement of the marrow over here, there's granulation tissue over here, and this is actually going within the epidural sac, epidural space. So this was likely to be due to tuberculosis. So if there are certain lesions or compression fractures, bone lesions, you're unable to characterize them on not using CT or MR, the next thing to do would be use a spinal biopsy. The spinal biopsy can be done using either fluoroscopy, like we initially described, or you can also use CT. So this was a patient where we used a bone needle, and we went through the pedicular approach to get the tissue. Now, another thing, what the interventional radiologists do nowadays is, suppose there is a compression fracture, due to osteoporosis. Now in this patient, you see there are multiple levels of compression fracture, and these compression fractures can give rise to severe pain. So what people do is vertebroplasty. You go through the pedicle and you inject cement, and this will definitely give relief to the patient. So once we're done with that, we go to other congenital spinal lesions, which this one over here, MRI very well shows you a presacral mass over here, and this turned out to be a sacrococcygeal teratoma. So after that, we're done with the spine. Let me just recap spine and the musculoskeletal system. So each modality once again has its own role, and even if you have high-end investigations like MRI, CT, your X-rays are indispensable. So you have to begin your imaging with X-rays, because there might be quite subtle findings like calcification, which might be easily missed maybe on ultrasound or even on MR. And of course, when we're talking about the spine, even though the X-rays are normal, that does not rule out any other pathology within the spinal canal, like small disc bulge or small disc protrusion. They can be a severe cause of severe pain to the patient. Now moving on to the reproductive system, basically we will be talking about the uterus, the ovaries, and the scrotum, and your obstetric ultrasound. So this is basically a bicoordinate uterus. This was a congenital anomaly over here. This is a hysterosalpingography. Okay, so what are the imaging modalities that we use? So one is a hysterosalpingography, ultrasound, and MRI. MRI gives you tremendous amount of information, which might help you in problem solving with certain issues. On ultrasound, you might not be able to, if there's a large pelvic mass, you might not be able to figure out where is it arising from. That's when your pelvic MRI is useful. So over here, this was a patient who had come for infertility, and this is the hysterosalpingography, which gives typical, the two endometrial canals over here, and this is your bicoordinate uterus. Adenomyosis is basically caused due to migration of the endometrial tissue within the uterine wall. Or this is over here. This is thickened endometrial myometrial junction. The Doppler will show you increased vascular flow within the myometrium, and over here this is your typical MRI appearance of a adenomyosis. Now adenomyosis is commonly associated with endometriosis. Endometriosis is basically ectopic endometrial tissue. You might find it anywhere within the pelvis. You might find it within the ovaries. This will give rise to chocolate cysts, and if it is seen on the ureter or on the colon, it might cause ureteric compression, or can be cause of severe pelvic pain. Another thing is hydrosalpinx. This is an MRI appearance showing a cystic lesion on the left side, and this was turned out to be a typical hydrosalpinx. Ectopic pregnancy. So talking about ectopic pregnancy, if a young female comes with severe pain in the abdomen with history of amenorrhea, this should be one of the top differential diagnosis in your mind. What you might find in ectopic pregnancy is you will find thickened endometrium. You might find free fluid in the pelvis. You might find an adnexal mass, and once you switch on Doppler, you might find a typical ring of fire appearance. So these are the signs for ectopic pregnancy, and very rarely you might actually see a live uterus or heart, a live fetus in the adnexa. Hydatidiform mole. It has this typical, these books describe it as a snowstorm appearance, and it has multiple tiny cysts within the endometrial canal. But nowadays, with increased resolution of the ultrasound probe and better images, that snowstorm appearance is less frequently seen, and you see more of a cluster of grapes sort of an appearance. So that's your hydatidiform mole. And when you switch on Doppler, you find significant increase in the vascularity. Obstetric ultrasound, the most common application is to confirm the pregnancy, identify the number of gestations, to look for viability of the fetus, to look for well-being of the fetus, and of course, when you do the anomaly scan, which is done at 18 to 22 weeks, it is quite important to evaluate, the central nervous system, the spine, the heart, and even the genitourinary system. Sometimes when your obstetric ultrasound picks up an anomaly, especially the CNS anomalies, fetal MRI might help you in picking up or problem solving in certain issues, because fetal ultrasound is an excellent modality, and this further MRI will just add maybe 10% of the extra information. Now, this was one patient who had agenesis of the vermis, or the Dandy Walker malformation. So this is a normal appearing fetus over here. So this is a normal vermis over here, and over here in this fetus there's a lack of central vermis. So this was a Dandy Walker malformation variant. So with this, I finish my talk on the reproductive system.